Rochester and at home right now. But normally I am at the university office, University Avenue office in Rochester. So we want to first recognize that 60% of deaths related to pregnancy are preventable. And because of that, improving Black maternal health outcomes requires systemic change throughout our healthcare system. And a lot of that change occurs at the government level through legislation. So there are a few things that are happening that I'll share with you at the New York State level, as well as the national level related to helping make improvements. At the New York State level, there was a bill that was presented to extend Medicaid coverage from 60 days to 1 year postpartum. And that was not passed in its full form. A sort of a different iteration of it was passed that would transfer people to the silver plan in the New York State marketplace. And that would provide them with the coverage. That is still, I believe, getting some examination, consideration for improvements and such, because some of the concern is that you might lose people along the way if you have to transfer from Medicaid to the New York State marketplace. People get lost in the shuffle anytime change is introduced. The other downfall with that is undocumented people are not able to access that. So there is still work that needs to be done to make sure that all mothers are covered with the care that they need, because we know that a lot can happen after 60 days and a lot happens within that first year postpartum, post-delivery. So there's still work happening. At the state level, there was also legislation presented to improve access to midwifery, I always want to say that the wrong way, midwifery-led birthing centers. And experts at the World Health Organization recommend and recognize the importance of having the assistance of midwives to have better, more positive outcomes in delivery. And that is an evidence-based approach. So that's some of the stuff that's happening at the state level. At the federal level, you're probably familiar with the Momnibus Act of 2021. And basically that's taking a comprehensive look at the situation of the negative healthcare outcomes and investing in policy to improve that for millions of women in the country. And according to the CDC, Black women are up to 4 times more likely to die from pregnancy related causes than Hispanic and white women. So in order to transform the change, policies have to be introduced. And again, at the national level, they're looking to expand Medicaid coverage, just as I had mentioned, was introduced at the New York State level. They're also looking to expand telehealth services. We saw during the pandemic how dependent people were on having access to healthcare using telehealth services. They're also looking to receive improved or increased support to community-based organizations and public health departments to better address the social determinants of health impact on maternal health care, and also ensuring safe and respectful maternity care during COVID to ensure that pregnant folks are involved in vaccine development as well. So there's a lot happening, a lot going on. I think I forgot to also mention continued support of implicit bias training, because we know that, and we've seen that across the country, even outside of maternal issues, where implicit bias would have helped in saving a life or just having a better diagnosis in the beginning. So we want people to be better trained and understand how to support their patients. So that is what we have happening on the state and national level. And I am going to move over and introduce our speakers. And sorry, I have to read this because obviously I'm not going to be able to memorize this. But first, we will start with Dr. Celia McIntosh. And she is a nurse practitioner by trade and a social justice advocate who is passionate about leveraging her skills, experience, and expertise to become a voice for policy and social change and reduce healthcare and social disparities. Dr. McIntosh has 17 years of experience in the healthcare sector as an educator, clinician, consultant, and human rights advocate. She received her Doctor of Nursing Practice and MS in Family Nursing and Postmasters in Psychiatric Mental Health Nursing from St. John Fisher College. She now works at Rochester Regional Health in the Neuroscience Center as a neurology nurse practitioner. And Dr. McIntosh is the president of the Rochester Regional Coalition Against Human Trafficking, vice chair of the inaugural Police Accountability Board of Rochester, New York, and a founding member of the Rochester Black Nurses Association, and vice president of Health Policy Chair and the chair of the Black Maternal Health Committee. Dr. McIntosh speaks locally and nationally regarding human trafficking, depression, stroke, and police misconduct. And following Dr. Celia McIntosh, we will have Marielle Rivera doing her presentation. And Marielle Rivera is a doctoral candidate at the Syracuse University and founding member of Sankofa Reproductive Health and Healing Center. At Syracuse University, Rivera's research focuses on how race, gender, and class impact maternal health in the US. Her current research focuses on Black and Brown doulas in Syracuse, and Marielle has been a trained doula since 2018. And she did this because she realized there were not enough women of color doing doula work. So that's what compelled her to go into this. She also offers virtual doula care as well as one-on-one childbirth classes and birth consultation. So we will go into both of our presentations, and please save your questions until the end after each of our presenters have done their presentation. So thank you again for joining us, and Dr. Celia McIntosh, I will turn things over to you.
All right, thank you very much. So I want to thank you for having me here today. I see several of our Rochester Black Nurses Association members here and two from the Black Maternal Health Committee. So I would say thank you, Teresa, Jemiah, thank you, Carly, for being here, and thank you, Dr. Yvette Conyers, our president, for being here as well. So thank you for this opportunity. So I am going to present today on the Black Maternal Health, the tragic truth. And we'll talk a little bit about our organization as well. So who we are, the National Black Nurses Association, we are a professional nonprofit nursing organization. We were established in 1971. We represent over 250,000 African-American nurses in the US, Caribbean, Canada, and Africa. There are over 117 chapters and over 3,000 members. The NBNA is the voice for Black nurses and diverse populations. We ensure equal access to professional development, promoting educational opportunities, and improving health. We were founded in 2018, chartered in 2019, and our motto is the heart of community health, bridging the gap. So whether we are speaking on issues around COVID-19, cardiovascular disease, stroke, sickle cell, or maternal health, we aim to bridge that gap. We launched the Black Maternal Health Committee in March of this year to bring more awareness to Black maternal mortality in the greater Rochester community. I say more because we already have organizations that are doing work around these issues, and we want to just amplify their voices as there is strength in numbers. In an effort to improve, really the effort is to improve health outcomes and address health disparities, also using a health policy lens to advocate for legislation that will improve access to services, diversify the maternal workforce, and services for Black mothers. Just going to open it up with a quote from Malcolm X. He says, the most disrespected person in America is the Black woman. The most unprotected person in America is the Black woman. The most neglected person in America is the Black woman. And 50 years later, that still rings truth. So we know that maternal mortality, when you look at the literature, there's varying degrees of the definition. Maternal death in the literature may state that that's death of a woman up to 42 days after her pregnancy. So for the purpose of this talk, I'm going to use what is pregnancy-related death, and that is when a woman dies due to complications of pregnancy or childbirth of up to 1 year after giving birth. So this actually goes back to 1986. The CDC began tracking pregnancy-related deaths to gather information and determine what was causing these deaths by creating the Pregnancy-Related Mortality Surveillance System. And when we look at it, 2021 now, and the United States still has the highest Black maternal rate. And we in New York State is 30th out of 50 states. So we still have a lot of work to do. We constantly are collecting data, but we still see that the outcomes are no better. So we definitely have a lot of work to do. So what we know is that severe complications of pregnancy affect over 65,000 women in the United States each year. I want to just ask a question here. How many people here work 12-hour shifts? If you can just drop that in the chat. And the reason for that is what we know is that we've often, according to the literature, you work 12 hours. So in a 12-hour period, at least one woman dies of maternal mortality within that 12-hour shift. So after you have completed your 12-hour shift, I can say that at least one woman has died within your working shift of maternal mortality, just to put that in context. The number of reported maternal mortalities in New York State has increased from 15 deaths per 100,000 live births to now up to 21. What we know is that Black women are dying at a disproportional rate, higher than that of white women. To be exact, 3 times higher, and the rate goes up to between 4 to 5 times higher than white women if you are greater than 30 years of age. On average, 700 women people die annually of these complications. The rate of pregnancy-related deaths has been on the rise for the last 30 plus years, but has increased 60% over the past 10 years in New York State. And essentially, this is just a tragic trend in the United States. Oftentimes, we know that your social determinants of health is also a factor. So when we look at this graphic here, death can happen up to 1 year after delivery. During the pregnancy is actually the lowest percentage. But when you look at women that have delivered up to 1 week after delivery, that's the highest time death may occur. But 1 week to a year out, there's not that much of a drastic change. So despite this knowledge, we still have so much work to do. We also know that your social status determines your health. Social determinants of health also contribute to maternal mortality rate. Black women also have normal. One of the things that you may hear people say is that oftentimes maybe they're obese and poor and unhealthy, but we know that Black women also with normal pre-pregnancy BMI had higher rates of severe maternal mortality. Many of those factors include issues with housing, public transportation, exposure to harmful chemicals or your environment. There's other community factors that play here, police, laws, poverty, racism. A couple years ago when I was doing some research around poverty, what we found out was that Rochester was the 3rd poorest city out of 75 metropolitan its size. When you think about and also in that document, they talked about poverty, childhood poverty being number 1 of women of children in predominantly maternal households. So the poverty rate, in addition to racism, in addition to laws, all impact women, mothers. When we talk about insurance companies, we know we heard Deborah talk about Medicaid expansion, and oftentimes we know that the insurance companies reserve the right to categorize pregnancy as a pre-existing condition, thereby making women ineligible for private insurance. Even access to Medicaid is curtailed for some women due to lots of bureaucracy and delays in coverage. Women have also reported access and mobility issues as to why they're unable to seek prenatal care. Definitely lack of transportation, lack of health insurance, and even if they have Medicaid, oftentimes many providers don't take that insurance, so therefore you really don't have access to care. Also, degrees are not saving us. When we think about education, as we saw with Dr. Shanice Wallace, who was in her fourth year of residency, medical degrees can't save us. So oftentimes society will have you believe that if you're poor and uneducated, that you are at risk. And what we know is the opposite is true. Women who do not have access to prenatal care are 3 times more likely to die during or after pregnancy than women who do. Higher education still does not improve racial differences in maternal mortality and is not protective for Black mothers in the way that they are for white women. We talk about education as stated, but the literature suggests that Black women with at least a college degree had higher rates of severe maternal mortality than other women who never graduated from high school. Essentially, when you think about young adults, they have the highest risk for fatal complications at any age. And of course, experiencing racism and discrimination in healthcare makes Black mothers less likely to trust the healthcare system, which further may lead to delays in care. So there is this idea that weathering and telomere connection, and I will try to explain this to the best of my ability. So weathering is essentially a biological response to social factors. It's a product of your lived experience and how that impacts you physiologically. So the term weathering really describes how the constant stress of racism may lead to premature biological aging and poor health outcomes for Black people. Like, for example, we disproportionately have higher rates of chronic conditions such as heart disease, stroke, diabetes, and cancer. There's also been some established conversation about mental anguish, and that's basically because you're constantly fighting against larger structures and systems, which can also impact your health. So kind of to explain how this kind of works, in the 2000s, there was research done on these telomeres, and essentially they're the protective caps on your chromosomes. And weathering is, we found out that each time the cells divide, telomeres get a little shorter. They eventually reach a point where they can't divide anymore. And you have this allostatic load, which is essentially the wear and tear on your body, which accumulates as an individual. You're basically exposed to repeated or chronic stress. So essentially these cells are really they deteriorate because they're trying to kind of repair themselves, and they essentially poop out. So therefore they deteriorate, they cause some deterioration to the organs and tissues, and essentially premature aging of these telomeres. So it just impacts your overall health. So when we talk about the medical causes of pregnancy-related complications, I put together this kind of acronym CHOPPY. And in neurology, we use a term called CHOPPY. It's spelled different, but we basically is defined as disjointed and jerky quality to care. Essentially a disjointed and jerky quality. So my point here is saying that if Black women continue to receive this disjointed and choppy quality of care, they will continue to have these complications and mortality. So 65% we know of pregnancy-related deaths occur within a week of the end of the pregnancy. Across the country, these seem to be the most common complications that I have listed here. We know that obstetric factors play a role in maternal mortality and morbidity. The C-section rate has gone up about 30% compared to vaginal deliveries. When you think about things like cardiomyopathy, you get enlargement of the heart, increased thickness, and possible rigidness, and therefore you have blood pressure issues, reduced heart function and heart failure, and oftentimes some hypertensive disorders as well. Leading causes of pregnancy-related deaths are heart conditions or stroke. They cause more than 1 in 3 deaths. When we think about hemorrhage, oftentimes severe bleeding can occur for these women. We know that we have the HELP syndrome, which is a complication of pregnancy characterized by hemolysis, elevated enzymes, low platelet counts, and there's various different symptoms that women can have, but they can also have some kidney failure as well. Of course, when we talk about infection, impacts of the amniotic fluid, influenza, various different things, genital tract infections, fever, chills, and when you're thinking about these things, if you have nurses or providers that aren't listening to you when you're talking, telling them about some of these symptoms that you're having, they're less likely to catch them earlier. Of course, we talk about preeclampsia, essentially 20 weeks at about 20 weeks after delivery, pregnant women can have the increased blood pressure, which creates a lot of problems. Also listed here is postpartum depression. It's less talked about, but it's another cause of maternal death. Widely untreated and underrecognized can lead to suicide, and suicide is one of the most significant causes of maternal mortality. And also embolism, where pregnant women are at higher risk for clots during the pregnancy because they're in a hypercoagulable state. Oftentimes they can have, DVTs, PEs, basically causing blockages to the brain, the lung, and the legs. And of course, there are other risk factors such as obesity and increased age, diabetes from C-sections. And the biggest takeaway here is, attending less than 10 premature visits is also associated with a higher risk of maternal mortality. So what we know here is that 60% of deaths are due to preventable causes, but why? We know that getting regular health care before, during, and after, especially with that 1-year follow-up, can help prevent them. But some of the problems that have been identified in the care of Black mothers, nurses not answering call bells, not interacting with patients, not giving adequate discharge instructions, making slick, smart remarks, not responding to their questions, and then just having the general health disparities is also a contributing factor. So when we talk about this here, Dr. Perry has an extensive amount of, she's a national expert on birth equity, and she talks about the impacts of individual and structural racism can compromise health over time, leading to poor health outcomes for Black women. And we know that that's essentially a fact. So racial and ethnic disparities in maternal health is a significant, public health problem. In 2019, the task force study that was done said that, the death was at some point between 2014 and 2016, up to 52 deaths per 100,000. We're decreased from that now, but it's still very high. It is important to recognize the role racism is playing in maternal and physical health, especially mental health as well. Discrimination plays a significant role in maternal mortality, as we've talked about with the weathering. And like I said, all roads essentially lead to racism when you start looking at the literature. And of course, poverty has a big portion to this as well. Racism and poverty are linked and visible in the data on hospital quality. We know that racism fuels power imbalances and subsequently creates barriers to access to healthcare, safe housing, and other institutions. We also know that clinical care is also linked to poverty and impacts maternal outcomes among Black women, just to name a few. So really here, some of the common issues that Black women face in the healthcare system is oftentimes they are ignored, they're not believed, there's a lot of delays in their care, they feel empowered, they feel invisible. So the purpose of this campaign is really it's a call to action for providers to really see her, and not ignore her. We often know that distrust in the healthcare system, as we talked about, often results in reduced encounters and the system associated with late and inadequate. So essentially, if you're you're going to an organization where you're supposed to be getting care, you're ignored, you're unheard, you're not going to feel like going to that place because it's not going to be a safe place. And if you're not going for it, you're prenatal care, then you're ultimately going to have poor pregnancy outcomes, low birth weight, preterm birth, and infant mortality as well. So it's this vicious cycle. So these are some of the women that have been impacted by maternal mortality. I would say that Serena Williams, when I just want to take a step back here, society will have you believe that only poor women are dying of racial disparities. But as you see here, there's Serena Williams, there's Cara Johnson, she had degrees, Dr. Wallace, Dr. Irving, they all had degrees, supportive families. Serena Williams complained about pain after she had a C-section and she had some shortness of breath. And instead of her nurse thinking, okay, recent C-section, shortness of breath, maybe this is a PE, she kept pushing her off. Felicia West died in 2019 of a stroke, and she was told by a provider, okay, we will, it'll be a while before I can see her because I have a lot of patients. Cara Johnson died in 2016, leaving 2 children and a husband behind, died of postpartum hemorrhage, and basically her husband was told, sorry, your wife is just isn't a priority right now, just to name a few. So we want you, again, just calling on you to really see her. Okay, just making sure, watching my time here. So essentially the system is rigged. This was actually one of Dr. Irving's friends, and she said, you can't educate your way out of this problem. You can't healthcare access your way out of this problem. There's something inherently wrong with the system that's not valuing lives of Black women equally to white women. So the consequences of not listening to Black women, essentially motherless children, broken families, lost mothers, persistent rising complications. So we need to fix this. And this was actually a little picture I found on Facebook quite a while ago. And it says we talk about the KKK with the police, but we need to also talk about the KKK in the hospitals and the doctors. So essentially what we want, improved diversity in maternal care, improved workforce. We want governmental accountability. We have heard Deborah talk about some of the legislation that that we would like, that would help us decrease the maternal mortality. We need supportive care practice of doulas. We need medication expansion. The literature suggests that Black women have better outcomes when their providers look like them and have a doula. I would also just touch base, when I was 22 having my kid, I didn't at that time realize that there were some benefits for me, having a Black provider at that time and not having a degree. I had no idea that those things kind of worked in my favor at that time, but but doing this presentation kind of brought up some of those things. So just to kind of finish up here, Medicaid expansion, we talked about. Definitely supportive care practices of doulas has the potential to improve health of both the mother and the child and reduce health disparities. These services are underutilized among low-income women and women of color who are at greater risk for poor maternal health outcomes. We know that one of the biggest problems is that Medicaid does not cover doula care during women's prenatal or postnatal period that I'm aware of, but Marielle will clarify that when she speaks. So what we ask you to do is listen to Black women, definitely advocate for legislation, follow best practices guidelines, but there's going to be some times when best practices guidelines is going with your gut and saying something doesn't make sense here, something is wrong, and really challenging status quo. And then of course, advocating for maternal justice. And my last ask is that you join us on Saturday. We are having a Candlelight Vigil for many of the women, to recognize and honor many of the women that have lost their life to Black maternal mortality. And the Zoom link is, I'll send the Zoom link because it's not on this one. But you can go to our Facebook page or our website, and we will get you the information, but join us on Saturday. Thank you.
Thank you so much, Dr. McIntosh, for that presentation.
Thank you, Dr. McIntosh. And now I'd like to welcome Marielle Rivera to do her part of the presentation.
Yes, thank you everybody for being here today. So I am currently researching doulas in Syracuse, and I really just wanted to touch on that last piece and looking at how doulas might benefit Black and Brown women, especially community-based doulas, and also they work to mitigate some of the negative outcomes that we have been talking about for Black women in maternal health care. So what is a doula? Just a general definition. So a doula is actually a Greek word that comes from women supporting women during birth. Doulas often have no formal medical training, although many of the doulas in my experience have a background in the medical field, whether they are nurses, medical support staff, or work in other aspects of medicine. And they really work on empowerment. They provide support both physically and emotionally, and also education on pregnancy from the prenatal period to the postpartum period. We are seeing an increase in doulas past pregnancy, so including the span of abortion doulas, miscarriage doulas, as well as end of life or hospice care doulas. And many doulas also use the term birth worker interchangeably. So if you do see somebody referring to themselves as a birth worker, they may be a doula. So just a general diagram of the scope of doula work. So we can see here the emotional support, which many women crave during their pregnancy, somebody to listen, somebody to affirm their experiences, and also somebody to debrief if they have negative or traumatic experiences. Doulas also offer physical support during labor, which I think doulas are most known for when you see the image of somebody kind of getting a massage, helping them switch birthing positions, etc. And then some doulas include empowerment in their work, so using advocacy, using referral to WIC and other services such as that, using language translation, and often having mediation with family members. They also traditionally offer education on multiple perspectives pertaining to pregnancy, birth, and postnatal options. And doulas have been linked to more positive birthing outcomes in general. So mothers that have had doulas were 4 times less likely to have a low birth weight baby. They were less likely to experience birth complications involving themselves and their babies. They were more likely to initiate breastfeeding. There's been shown to be a decrease in the risk of cesarean section and an increase in vaginal birthing. There's been known to have shorter labor times with the use of doulas, and also a decrease in medical interventions for pain relief, such as epidurals. Unfortunately, we have seen many barriers for doulas in terms of their use. And many times we hear people discussing the payment of doulas. So some private traditional doulas may cost as much as $1,000 or more for the whole prenatal through postpartum care. We also know that there is a lack of availability of culturally similar doulas. So as Dr. McIntosh mentioned earlier, having somebody provide care for you, if they look like you and have a similar background of you, can have more beneficial outcomes in terms of maternal health. And we also know that there's an overall lack of knowledge about doulas. So oftentimes clients might come to us and say, you know, I didn't know about your doula services, or I didn't know that these services were available in our city, etc. So just having the awareness can sometimes be a barrier for people in achieving doula care. And within the scope of doulas, there are a variety of different types of doulas. So one specific type of doula which is evident in many Black and Brown communities, is the use of community-based doulas. So these are doulas who have been trained and live within your community. They often have the same background, race, gender, ethnicity, etc. as their clients, making their relationship stronger. And they usually provide extended services like sliding scale payments or low to no cost care, which alleviates some of the barriers of the financial aspect of doula care. And many of the community-based doulas have been trained and utilize a reproductive justice model within their care. So this is a quick quote from Advancing Birth Justice, which was written by Esther Bay and some of our other doulas that we work with throughout New York State. And really this looks to describe community-based doulas as those who center African descended people, Indigenous families, and people of color. We also see that community-based doulas consider how physical, emotional, and mental and spiritual experiences impact pregnancy, labor, birth, and the postpartum period. Community-based doulas utilize a human rights framework, and they promote health equity, reproductive justice at all stages of maternal health. Within Syracuse, I have been lucky enough to be a co-founder of Sankofa Heals, Reproductive Health and Healing Center, which is an official perinatal safe spot dedicated to providing equitable care while uplifting ancestral practices and promoting healing and wellness for reproductive justice. The Sankofa Heal Center is a partnership with Village Birth International, Doula for a Queen, and Zenji Yoga, and we offer a variety of courses, events, and workshops that center birth work and reproductive wellness. So Village Birth International offers our community-based doula trainings and policy advocacy for reproductive justice. Doula for a Queen offers weekly childbirth education classes. Currently, they are virtually, as well as community-based doula care. And finally, Zenji Yoga offers reproductive wellness yoga and writing workshops that center the lives and healing of birthing people of African descent. Through this collective partnership, we have also formed underneath us the Sankofa Doula Collective. And right now I wanted to introduce Tree, who is a LPN, PCC, and also a community-based doula. And Tree is going to talk a little bit about her experiences and what she has accomplished as a doula.
Hello, everyone. So there are many factors that goes into being a doula. I've had clients that a young woman who was homeless, so to speak, she didn't have a place to stay. So helping her find a place to stay, finding her furniture, everything from pots and pans to sheets. I even got my church involved to assist in things that, you know, they had known resources for, and we were able to situate it in a prenatal center for her to stay at and live. And she stayed there until she gave birth and was able to, you know, get on her feet and get her apartment. So even assisting her with governmental assistance and things like that. Had a client where she went to the doctors for her initial prenatal appointment. And 4 months later, she was asking me about WIC and how do she sign up for WIC? And so I had to, you know, just let her know those are some of the things that are supposed to be done at the initial prenatal appointment. You should have gotten a form for that. And so I, you know, told her to contact her doctor's office and see if they had the form. And then if she didn't get anywhere that way, to contact me. And I also sent her, there's a way to sign up for WIC online. So I sent her that link as well. I've had patients that didn't feel comfortable being vaginally checked every time they were at their doctor's appointment as a nurse / doula. And, you know, you tread on thin water, but it's advocating. If you don't feel comfortable being checked vaginally at 37 weeks, that is fine. And it's okay for you to govern your body and feel okay and empowered to tell your gynecologist, your obstetrician that, not today. I don't feel like it today, or, I want to wait a little bit longer. So there's several things that, including like setting up the baby shower virtually, helping with those things. So we do a lot, and we navigate through a lot. We empower our mothers, and as well as the fathers as well, family. So it's like all encompass. I've seen where the pandemic hit, and that was tough on a lot of moms, where they weren't letting doulas come up, and sometimes it's building that relationship with the hospital, or even the obstetrician, so that they'll know ahead of time if dad cannot be there. Then absolutely, as a birth worker, as a doula, as another support system, to ensure that her needs are being met, and there's a healthy baby being born, that helps as well. So when you do get to the hospital, some obstetricians, they're good. They'll let the hospital know, and it's kind of in the patient's record. So, yeah.
Thank you so much, Tree.
You're welcome.
So I think that Tree's examples really highlight that community-based doulas fill a lot of gaps. We have seen Dr. Cecilia raise some of the gaps that we see that might not traditionally be linked to maternal health care, but we know have ultimately outcomes on the healthy birth and the postpartum period, and the survival of Black mothers. So to support New York State doula care, there have been 2 bills put forth recently that are looking to directly uplift doula care. So the first bill was the New York State's Medicaid doula pilot. This is directly off of New York State Health Department's website, where they explicitly pointed out reducing racial disparities and health outcomes. So we know that this bill was looking to fund doulas that work with Black and Brown mothers specifically to alleviate those health disparities. However, we can point to the fee page that was provided by New York State and see that they aren't adequately reimbursing doulas for the work that they are doing. As Tree mentioned, our work traditionally as community-based doulas is not just limited to a prenatal care visit that might be an hour long, right? We might be on the phone with our clients. We might be going to their prenatal OBGYN visits with them. We might be transporting them, if they have to go to the WIC office, etc. So that is not, that would not be covered under this fee-for-service schedule. And we also know as doulas that the labor and delivery can last days. Women may be in labor not only in the hospital, but they may be laboring at home with their doula for days or hours before the actual delivery. Dollars would not be a justifiable reimbursement for 24 hours plus work. And the same goes for postpartum visits. Many of our doulas go above and beyond for their clients. They help with, providing infant care, providing breastfeeding support, providing meal preparations for their clients to ensure that they're eating healthy foods after postpartum. So that is, again, going to go beyond the scope of $30 per visit. In reaction to the Medicaid doula reimbursement bill, some of the community-based doulas across New York State have uplifted or suggested recommendations for Medicaid reimbursement. So just some of them are, of course, ensuring that doulas have the opportunity to earn a living wage. Many of the doulas that we know are Black women themselves coming from a community. Many of them work full-time. So making sure that they are able to earn a living wage, and if they want to, they are able to participate as a doula full-time. Collaborating and investing with community-based doula programs is another recommendation. We also see ensuring adequate training, certification, supervision, mentorship, and peer support for doulas, providing funds to train and certify diverse doula workforce, especially at underserved rural and urban low-income communities, communities of color, and communities facing linguistic or cultural barriers. And then also incorporating community engagement as an essential component to improve health equity. We need to take these steps to raise awareness about the benefits and availability of community-based doulas. Another bill that was more recently presented by New York State is a bill that would look to certify doulas or regulate the certification of doulas. So this was also met with some resistance from community-based doulas. Specifically, some of the responses to the bill from Village Birth International included their concern about the language, which stated the use of the title certified doula. So they believe that that use would be extremely problematic and detrimental to all individual and birth workers across the state. Another important reaction to this bill was the use of the term character of doulas. So the bill actually discussed doulas must be of good moral character as determined by the department. There is a concern of this because it is clear that that could be subjectively taken and also implicit bias in determining what is good, quote unquote. And finally, VBI is really concerned with this notion that there is an examination requirement. We have many doulas who might not have English as a first language. We have many doulas who would not have the availability or time to do large amounts of paperwork. And also this notion of having fees to determine if you can become a certified doula in the state or not. So I think it's clear that moving forward, especially in New York State, there needs to be funding and commitment behind community-based organizations who are already doing this work. They need to be uplifted. And we can see in the example of the Sankofa Heals that we have a very specific community orientation. We work with people who live and are born and raised in Syracuse and know Syracuse. Having the ability to have doulas who come from the city, who have lived in that city and who experience that city is vital to the care that we provide. We also know that we need to uplift the training within our community and provide more resources for community doulas to continue their training. And also funding these doulas at a living wage. As a doula, we know that the hours are long, they may be unexpected when a birth occurs, etc. And having that living wage could make our care and providing the care in the community that much easier. And some more recommendations, of course, having more education for healthcare professionals so they are aware of the benefits of doulas. They can suggest culturally specific doulas in their community to their clients, and also an awareness of when we show up to the hospital with our clients, knowing that this is what a doula is, this is their role here. They are part of the care team for this laboring person. Thank you.
Thank you so much, Marielle and Sri and Dr. McIntosh. That was incredible. You can check out the chat and see everybody's raving reviews of today's presentations. And now we're going to get into some Q&A. So feel free to put your questions in the chat. There was a couple that came up throughout the program, so I'll read those now. One question from the beginning of our program: do we have more local data on the disparities in maternal health outcomes? So Rochester, Syracuse, I don't know if anybody has any information on that to share now. As a side note, I do plan to send out a follow-up email to everybody who RSVP'd for today's program with some additional links and resources. So we can always also share some resources with you all afterwards as well.
Yeah, I guess I could answer that. So some of the information I received was from the New York State Task Force on Maternal Mortality and disparate racial outcomes. And this was a document from March 2019. And I believe there are some forms on the government website, the New York State website. So I could provide you a couple links for that email you'll send out.
Perfect. Thanks.
And if you, we do have our vigil on Saturday, and there are some more resources in there that we'll kind of go through when we're doing the PowerPoint, but I will send you those 2 links.
Perfect. Somebody had asked, are doulas still allowed in the room, in like a hospital room during COVID? And someone in the chat said, currently in New York, yes, but not without barriers. I don't know if either of you wanted to comment further on that. I know towards the beginning of the pandemic, it was very strict and then it relaxed a bit.
Yeah, I believe in April or maybe in May, the governor did have a statement saying that doulas would be considered essential workers and they would be allowed in the birthing room. But we have definitely faced barriers. We know that some of the CNY doulas, which are more traditionally non-women of color, have been given access to birthing rooms compared to some of the doulas that we work with who have reported to us that they have been, kind of questioned a little bit more, interrogated, I guess is a better word to use, in terms of if they are actually doulas. So I think that has been unfortunate to see, even with us, presenting, some of our doula collective members would present a little card that demonstrated they were certified. And depending on who the nurse in charge was, they might be interrogated, they might be asked to leave in specific situations. So that is definitely something that we've been working on in Syracuse.
Thank you. Angie in the chat asked, do individuals volunteer to be doulas as well?
There are programs, and it's just a matter of where those programs are. They have been more online, remote, virtual programs due to COVID, but it's just a matter of researching your area to see if your area do have classes for becoming a doula. So it is something that you have to sign up for, and there is training that comes with it.
Many of the doulas that we work with also have been trained, so they do pay for training and for their certification, and then they usually are kind of working with their families in terms of what the families need specifically, and then also in terms of what the payment would be specifically with that family.
Mariah asked, where can we find more information about the Black Maternal Health Committee? I can send out a bunch of information about that in the email if you want to wait for that. I can include all of that information. Jillian asked, how can we promote postpartum doula care in our community more?
We are actually currently working on a postpartum care program in Syracuse, but I definitely would suggest if anybody has access to a doula to talk to them about their postpartum packages. Many doulas will offer it as an add-on to their traditional doula care, but definitely asking if your doula can provide that would be a key. And also I know in Syracuse, we do have some doulas who actually prefer to work postpartum. So they actually will come in and kind of tag team with a birth doula and help them with that postpartum care piece.
Awesome. For the sake of time, it is almost 1 o'clock. I think we'll take this one last question. What avenues can be taken to integrate community mindedness into the stricter hospital environments and with physicians?
I think we have to keep talking about the issue of racism as a public health problem, and really, like I said, just bringing awareness to it, because at the core of everything is racism. I know a lot of organizations are starting to have like diversity inclusion committees. I'm just wondering if you want to do a more active role if you're a nurse, maybe starting your own kind of committee within the hospital organization to start bringing more awareness to that issue. So that's kind of where I would start.
I agree, definitely, be more active rather than passive with trying to speak with, if you're working in an office or a hospital, speaking with management, human resources, going to them, putting the offer or the suggestion on the table. Sometimes it'll be shut down. You can also fight collectively with your coworkers that are Black and Brown people. We've had to do that, collectively come together and fight for diversity, inclusion training. And it took us a couple years to get it, literally, but it did happen. Did it help? It's just something that's ongoing. So I would definitely say collectively get together. If you have to sign, a document and then send it off to human resources or anything like that, I would definitely say give that a go. And if it's not looked at or addressed, keep going. Don't stop there.
And I also think, as Deborah talked about earlier, having more out-of-hospital options is, I think, very important, and having more emphasis on midwifery care when we do have especially low-risk births.
And also, it just came to me when we have these type of platforms, inviting some of the hospitals in the Rochester area or the Syracuse area of people that do have the ability to make a difference and start the change, so that they can sit in on exactly what Black and Brown people are dealing with, moms and the deaths, mortality, infant and maternal. So I think that is another way of advocating and trying to get our voices heard.
Yeah, I guess I just want to piggyback off what Tree said. Yeah, definitely inviting. I mean, right now is a good time to have speakers come in virtually. You probably can do, like I said, I don't know your department, but having someone coordinate a grand rounds, that you have different individuals or maybe a panel coming in and talking about some of these issues. Because like I said, if we don't face it, we can't really address it. We have to be able to talk about these things, and as uncomfortable as it may be, the numbers just keep going up and up and up. So we need to really, like I said, put a dent in these issues. So keep talking about it. Try to see if someone can coordinate a grand rounds, and if that seems to be too daunting, maybe, like I said, even doing an in-service at your level to start educating other people to get their buy-in.
And I'll add something that I heard last night. Kimberly Crenshaw was one of the presenters at Planned Parenthood's national conference. And she said, if you haven't experienced something, you probably aren't culturally competent to make a decision. And there was also an earlier conversation on cultural humility. So cultural humility has a lot more value than cultural competence, because we hear people talk about cultural competency all of the time, but that will only take you so far. And sometimes when you're not of the group that's being discussed, whether you're not trans, you're not a person of color, you're not a person with physical or mental ability challenges, you might not be the best person to be coming up with the decision to resolve the issue at hand. So that cultural humility versus cultural competence will come in really handy, especially in these maternal mortality cases.
I'm sorry, I do have to add one more if you don't mind. We talked a lot about social determinants of health, but we definitely have to focus on the political determinants of health, because that's where we're going to make the change. So if you, like I said, if you can't rally for these things at the organization level, then, you know, start looking at how you can influence policy, start talking to your legislators, get with organizations that are doing this work, volunteer your time. That's the main thing that I would say, because policy, at the end of the day, that's where the change happens, policy.
Absolutely. I think that's a great point to end on. So thank you for adding that in. For the sake of time, unfortunately, we could go on, but we want to respect everyone's time. I know everyone's very busy, so we're going to wrap up. But thank you all again. Thank you so much to our speakers for joining us and offering your knowledge to us. And thank you for everyone joining us to watch and learn today. I learned a lot. And keep an eye out on your email for some follow-up resources, because we hope to continue this conversation well beyond today. So thank you, everybody. Take care. Have a great rest of your day. Bye-bye.
Thanks. Bye-bye.
Thank you.